2024 NEI Synapse features an educational program chock full of the latest advances in psychopharmacology and cutting-edge research on treatment strategies, side effects, drug interactions, and management. If you have yet to do so, register today for the 7th annual event being held April 19th through the 21st, in person in Las Vegas and online via simulcast. Use discount code PODCAST to save $100 on your registration at nei.global/synapse. Discount good on new registrations only.
Welcome to the PsychopharmaStahlogy Show, a special NEI podcast series. In this show, Dr. Andrew Cutler interviews Dr. Stephen Stahl on the most controversial, novel, and exciting topics in psychopharmacology today.
Hello and welcome to another edition of the PsychopharmaStahlogy Show. And today we're going to be starting a series on untreatable dimensions of psychopathology, problems that we face that we don't yet have good treatments for. With us today is a good friend of mine, Dr. Richard Keefe, and we're going to be talking about cognitive dysfunction. Rich, how you doing?
I'm doing great, Andy. Thanks. Thanks for having me on.
Yeah, we're looking forward to it. And with me, of course, is Dr. Stephen Stahl. Steve, how are you?
Really good. Looking forward to it.
Yeah. Well, Steve, why is cognitive dysfunction important? Why should we worry about this?
Well, it's what makes you a human in part. It certainly is related with creativity and all sorts of, functioning. We'll stay away from the politics of whether your cognition is fully present or not, but it comes up in all sorts of walks of life. And we don't always lose it quickly, and some of us never get it. So there are disorders of cognition. It's most interesting to me as a dimension of psychopathology that cuts across lots of different disorders. And of course, Richard will tell us the different flavors of it, but cognition is not one thing. And so, you have the ADHD type of cognition problems, and you have problems concentrating as a symptom in the DSM of mood disorders and anxiety disorders, let alone the dementias. So, it really is one of the top things. And one of the reasons we maybe don't talk about it as much is partly those of us in practice don't really feel that there's often a lot of treatments for that. So we don't actually categorize it very much. We tend to categorize the things that we can fix. And so, and we don't do as good a job of categorizing cognition as we should. Richard's the expert on that. So like to hear what he thinks about it.
He sure is. Well, the other thing is, I think for a lot of clinicians, it's kind of daunting. Cognition is such a complicated, big area, and I don't know how to assess it. And so let's get started, Rich, maybe let's think about how do you categorize the different domains of cognition, and how should clinicians think about cognitive dysfunction?
Yeah, absolutely. So a couple of things, because you've already stimulated new ideas for me, but I totally agree with the idea that particularly in medical backgrounds, right? It's not something that you learn how to evaluate. It's generally seen as the domain of psychologists like me. And so I think that the average psychiatrist is more likely to kind of put that off to somebody else. And that causes a bit of a problem because the people who are doing a lot of the treating in cognition are the people who are not necessarily experts in assessing it. And I think that's created some of the problem. And untreatable, at what point do I get to object to the untreatable part of this? Because I think that there are some things we can do in the short term. And in the longer term, I do think that there's some good likelihood that we have some treatments coming. So I'm very excited to be able to talk to you guys about this. When you look at a cognitive impairment in schizophrenia, the most striking part of it is the severity, right? There's a lot of different domains. I'll talk a little bit about that, but it's the overall severity. If you look at the average person with schizophrenia and compare them to the general population, they're performing in about the lowest 5 to 10%. And so it's very striking. It's actually very obvious. You don't really need a cognitive assessment battery to recognize that in someone with schizophrenia that there are some cognitive limitations. If you go down and dig a little deeper, you see that there are memory problems. There are attention problems. One of the aspects I think that doesn't get as much attention from the field, but is really important, is processing speed, right? The ability to keep up with everyday life. And, that's functionality, right? Just the way we're talking now. We need to all keep up with each other. Whenever you do anything, go grocery shopping, try to get a job, have a job, you need to keep up the pace with productivity and with what other people are doing. And I think that's probably the thing that is most challenging in people with schizophrenia.
Do you think that predates the onset pretty much consistently? And is it something that develops? In other words, are you born with cognitive limitations, or do you have them and lose them first before you lose your rationale?
Yeah, both, Stephen. So if you look at the studies of people who will develop schizophrenia later, they tend to perform worse in school. If there's been any standardized testing, they tend to be a little bit worse, but it's not identifiable. I said before, if you see somebody with schizophrenia, often you can say they're having cognitive problems, but you can't go into any classroom and say, oh, this kid is suffering, he's going to get schizophrenia. The deficit is about half of a standard deviation, versus 2 standard deviations in the actual patient. So there's a decrement to begin with, but it gets worse over time prior to the onset of illness.
Would you say that cognitive impairment is a core deficit of schizophrenia?
Yeah, I absolutely would. There are arguments and strong arguments, I think, that cognitive impairment is the core deficit. And that's the thing that goes wrong with young people whose brains are developing, whose personalities are getting socialized to the community around them, that not having the cognitive skill to navigate through that very challenging world causes people to retreat into themselves. And that retreat is the thing that leads to the hallucinations and delusions that we see a few years later.
Okay. Wow. That's fascinating. You stimulated something else in my thought when you talked about processing. I realized that cognition has both an input and an output. The input, you have to process and integrate information coming in and then figure out what's the right thing to say, what's the right behavior. That's kind of the output.
Yeah. I
hadn't really thought of it like that before.
Absolutely. And, and that's why when people ask questions about, what's the most important aspect of cognitive impairment in schizophrenia, it's kind of hard to answer that, because even tests of memory, right? They're tests of encoding the information, maintaining that information, and then finding a way to express it. Those are all 3 different cognitive elements, and you can't separate them from one another in a standard cognitive test.
Now, Richard, I'm going to indulge myself and ask you a question I've always wanted to ask you, but I haven't ever taken you aside at a meeting to do this. To what extent is cognition a little bit like the Fab Four? In other words, when I teach this as someone, and don't laugh at me because I'm not, of your ilk, I'm just a modest clinician. I say, you've got Paul, who wrote the songs, and he was, of course, the processing guy and the working memory. And then you got John, who wanted all the attention, and so there's attention. And then you got George, who was the culture carrier, and he had the memory. And then Ringo was the processing speed on the drum. And what I'm thinking of is that if you want a good Beatles hit, you got to have all these guys working in sync. But any one of them who isn't working right, have you ever seen how they can take a recording and mess up one of the lines, not the others? So like, say the processing speed guy is really not drumming to the read of it ruins the whole output. And so to a certain silliest extent, I've tried to explain it as that, and that any one of those that goes awry can mess the whole thing up. And of course, all of them can go awry in their own way. So to what extent is that so bad, Richard, as a metaphor, that you say, Stahl, knock it off, don't tell our people that because it's too simplistic?
I love it. I'm so overwhelmed by picturing all of the 4 Beatles together and what happened when one of them's a little, I don't know, this may be off the topic here, but watching, that Get Back video where you're watching the Beatles create music together was one of the most fascinating videos I've ever watched. And if you think about how that did require all those elements to come up with a creative process, to me, that's the pinnacle of cognition, right? Obviously, the creativity of the Beatles is like, humanity is one of the pinnacles of humanity. But a lot of cognitive processes do have that complexity to them, and that higher cognition itself is an incredibly intricate process. Right. And so if you don't have one of those things that you need, whether it's processing speed or memory or attention, you don't have a hit, you don't have a song, you don't have anything at all.
Mm-hmm. And I'm wondering, from a pharmacological point of view, then, if we're going to be lucky enough to say that the circuits will sort that simply, and whether the neurotransmitters will sort to measuring the circuits so simply. So, maybe it's way too much to ask to say, well, there could be targets for cognition that parse into those four beetles, and that maybe you can hit cognition that is memory different than cognition that is attention, etc. And that's part of the quandary, isn't it? Is to try to figure out what circuits are driving these different functions, and then maybe what neurotransmitters are regulating these sort of inefficient information processing in a circuit to try to make it efficient. And therefore, so that's still part of research, but it may be too simplistic a model, and maybe we'll never find it because it's going to be more complicated than that.
Well, I think, and I know I'm wading into your area of expertise here, Stephen, so please forgive me, but I think that the issue there is that as beautiful it is to watch the Beatles come up with something, I think the complexity of brain function, right, the pharmacology, neural circuitry, and its tendency to adapt to whatever problem it's having, which then, creates a whole new neural circuitry using a differential pharmacology. It becomes very complex to address a problem because of the brain's attempts to deal with the initial insult, whether it was cognitive or neuroanatomical.
You're right. The circuits learn. And I sometimes call that diabolical learning, evil learning.
Right.
So and then they like it. They say, oh, I love this inefficient information processing. Let me keep doing this. And so to knock them back out into efficiency is not so easy.
Exactly. Yeah. And it's like an athlete who practices the wrong thing over and over again.
Yeah, exactly. Bad habits.
Worse athlete.
Yeah. So, Rich, for the clinicians listening, let's just start out with what are the domains that are clinically important? So Steve mentioned those four. How would you help clinicians to understand the domains so that maybe they can start thinking about how to assess them?
So I think that processing speed probably is number one. These are, there are cognitive tests for all these things, whether it's the standardized thing like the matrix battery, which is used in clinical trials. There are ways of evaluating this by even talking to people, talking to a primary care provider, somebody who spends a lot of time with the person with schizophrenia. That's another way to address them. But something like processing speed, keeping up with things around one. Working memory, that's basically short-term memory. I tell you something and do you remember it for the next 10 seconds, something of detail. Verbal memory, like just somebody gives you instructions, directions. Can you hold on to those as you go forward over the course of the next few minutes into the next day, week, year? Executive function has always gotten a lot of attention. The idea that this part of the brain that kind of sits over the rest of it and allocates resources based upon the need. Should I be paying attention to this or that? Should I be remembering now or should I be planning? That kind of thing that's also impaired in schizophrenia and somewhat strikingly so. And I think it's been very sexy. Executive function has always been sexy because it's your prefrontal cortical function and people to think about that as the seat of humanity somehow. I don't really think it's that simple. But I think that those aspects are important. Plus, there's this other area of work that's very important, which is social cognition. Right?
Oh, yeah.
How you feel in social situations, paying attention to social cues that are sometimes different than cognitive cues because they carry this emotional valence that in everyday people, right, in the healthy population, you capture that information really quickly because your brain, right, the primitive brain is wired to see emotionally valent things quickly because that has been adaptive over time. And that is sometimes those aspects of cognition are separable from the rest of the cognitive things and also impaired in people with schizophrenia.
Yeah. That's a fascinating concept, the idea of how cognition and emotion relate. There's a famous book, Descartes' Error, which talks about this duality, this separation of the two, and yet they really do work together, don't they? Cognition informs emotional reaction, your emotions inform your decision-making.
Yeah. Yeah, I mean, there's whole careers and have been built on the idea that you feel something first and then you try to explain why it is that you feel that. Mm-hmm. Those are they are different systems, and they do operate at a different rate.
Yeah.
So, Richard, I've always wanted to ask, what is insight a cognitive function?
Insight, yes, it's a cognitive function. Yeah.
So, which one would you put it in? If it's to belong to one of those four simple domains that I mentioned, or is that one of its own?
Yeah, I would put that more in the executive function realm, right? It's one of the if the executor, right, the executive function oversees all the other aspects of cognition, insight is the way that the being looks at itself, and so therefore observes the other aspects of cognition and tries to make sense of things.
Now, one of the things that I think we neglect in our teaching and has come home to root when we're working at this Care Court initiative in California to decide if you want to have, if you will, mandatory hospitalization and treatment for people that can't make healthcare decisions for themselves as opposed to people who are violent, which is now the new criteria. I mean, if you're violent, you've committed a felony, you can go into decriminalization processes if you're lucky. But now there's this new idea, and it's right up your alley. It's called anosognosia. We don't really talk about how the fact that you don't even know what you don't know, and that part and parcel of, it's not the only illness, but if a patient doesn't know he's sick or she's sick and can't understand why medicines work or can't see that they're getting better,
right?
That's part of the illness and part of the problem that we have in allowing people to make voluntary decisions, and they often make decisions to refuse medicines because they're not sick and their treatments don't work. So one of the things I like to do is I wish, instead of delusions and hallucinations and thought disorder being sort of the classical teaching of schizophrenia, this cognitive thing probably needs to be emphasized more, the dementia precox, if you will. And then the element of it, which burns us all the time, is anosognosia. And you tell a medical student, I think you guys can all remember if you've seen a right hemisphere, left-sided body stroke, and you say, give me your left hand, Dr. Stahl. And I say, I don't have a left hand. And then they pick it up and put it in your face. And I say, what's that? Right. Well, that's maybe the most extreme form of anosognosia. I don't even know it's my left hand. But that's clearly a cortical function, maybe even a non-dominant hemisphere, at least in crude forms. So I just want to say, I think that part of the service of this podcast is to say people need to be more aware of the cognitive elements of all illnesses. And we're talking about now schizophrenia. And maybe this insight is a form of cognition.
Absolutely. I could do a whole podcast with you on this subject. I think it's a tremendously valuable and important one. If you go back 60 years to the WHO evaluation of schizophrenia across multiple countries and cultures, insight was the number one symptom that was found across every culture in schizophrenia. And the other thing, going from 60, 70 years ago up to right now, Javier Amador, right, has done a lot of work on anosognosia, has a book titled something like, I'm Not Sick and I Don't Need Help. And obviously that lack of insight leads to a lot of treatment failure in people with schizophrenia. And then third, some very recent publications from Phil Harvey, Jim Gold, and Stephen Luck focus on this concept of introspective accuracy. And so they're looking at the things that people with schizophrenia can identify in themselves and things that they can't, and have some very elegant theories about how they're trying to develop therapies where patients take advantage of the things that they do know to try to learn how to inform themselves of the things that they don't know. And that may be a way to cognitive behaviorally help patients with the development of the delusions and their lack of insight.
I love that. It's a part of the brain that ain't working because you have agnosognosia. Then you grab some spare brain.
Yes.
Someplace that's working on something else. And maybe it has to work really hard to do something that it wasn't really supposed to do. But maybe, that's a part of the theories of all sorts of rehabilitation and stroke and so forth is to get the brain to work.
That's right. Neuroplasticity in action.
And it gets down to problems that are really transforming the delivery of healthcare and we're seeing this revolution again in California, where we're beginning to say it's wrong for people to have their agnosognosia and die with their agnosognosia.
Yeah.
And live in homeless camps and get exploited by people and, in prisons, and that's their outcome, where it's very true that in other cultures that actually kind of are a little more paternalistic and maybe a little bit, pushing people a little bit more towards treatment when they don't want it. People don't have the ability to refuse healthcare treatment or to admit to healthcare treatment until they're treated. So we've even involved the Vatican because, Richard, I don't know about you, but I have no morals or ethics, and neither does Andy, because, as mental health professionals, of course, we have this dismal history. So if you can say, I, great expert that I am, will tell you this is ethical, people say, and you're in the mental health field? Yeah, right. So we're trying to borrow that, actually, some programs with the Vatican, and trying to say, in neuroethics, to say there's a dilemma. Do you actually push somebody to get treatment and housing in the greater service of bringing them towards, a better outcome and maybe they'll have more insight?
Yeah.
Or do you just let them have their rights on as we do now? And so right now, I think there's a movement towards trying to push against that, liberty at all costs. And maybe because of the anosognosia, they need to have that fixed a bit. Maybe they can grab that spare brain, Richard, and have a little bit of insight about why they need to be treated.
I don't think anybody would argue, or very few people would argue, right, that someone has the right to impulsively take their own life. I think anybody with the wherewithal would try to stop that person from doing something that they know that they would regret. And so this isn't quite death, but it is living a life of dysfunction. And so isn't there some responsibility for the rest of us to help out those who are going through a period where they struggle to see that what they're doing is going to be bad for them, Yeah.
I think so. And this is why I want you to find me a cognitive drug and treatment. Will you please, Richard? Because one of the things that could happen is that if you can really target this insight problem, maybe people will accept the treatment and the housing that really is in part there.
Yes.
And, but for this anosognosia going away and but for their cognition being better, they're the victims of this illness untreated.
Yep. I mean, I know we'll talk about this at some point, but there are some drugs in drug development pipeline that we're hopeful may make a bit of a difference. I don't know about curing cognitive problems, but.
Yeah. No, I liked your earlier comment, Rich, about it's not fair to say untreatable. There are interventions that we have, and I do want to get to that a little bit later, of course. And I know you've devoted a lot of your career to trying to help industry find treatments. You were one of the absolute drivers behind the Matrix, for instance, and we'll talk about the Matrix battery. But I have a question that comes from my experience doing the PANS, which of course is the gold standard rating scale for psychotic symptoms used in antipsychotic clinical trials. And that's about abstract thought. That's abstraction is also highly impaired in schizophrenia. And I'm wondering where that fits into the cognitive pantheon that we're talking about.
That's a good question. I'd have to give that more thought. I always see abstraction as something that is more in the executive function realm. And so you have some reasoning and problem solving tests. For instance, in the Matrix battery, there are tests, like maze tests and things where you have to try to picture how I would get myself out of a jam. But they're more concrete. The problem with tests of abstraction, Andy, even though they're important concepts in schizophrenia, is they can be difficult to test simply. And so therefore it's tough to do it in the course of a clinical trial. But the ability to understand abstract concepts is very important. I don't know that if we don't know if it's something that would respond to treatment or whether it's something that is just a side effect of other cognitive problems.
Yeah, I mean, the classic way we evaluate that is the Proverbs, for instance, and things like that. And it seems to me, if you have trouble abstracting, you're going to be impaired, certainly socially. You won't get maybe humor or metaphor or things like that. It's really can be impairing.
Yes.
As we know. All right, let's move on a little bit to cognitive impairment, as Steve said, is really crosses domains, right? It's an aspect of almost all of the DSM, really most of the major mental illnesses. But how common is it really? I mean, we know that patients can vary. There's a range of cognitive impairment.
Mm-hmm.
Not everybody has, with schizophrenia, for instance, has severe cognitive impairment. There are different levels of it. So how do we think about how common it is?
Yeah, it's a great question. So the thing to understand for people listening is that cognitive impairment is not a dichotomous variable, right? It's not like, oh, you're normal or you're impaired. Right. It's every distribution in psychiatric illnesses. If you look at the distribution of cognitive impairment, it is the upside down U shape. Mm-hmm. And so that there's that inverted U can get shifted down for certain disorders. And if you look at schizophrenia, it's inverted. It's an inverted U shape, but it's just shifted about 1.5 to 2 standard deviations below the general population. If you look at it in bipolar disorder, same thing, inverted U, shifted about 0.8 standard deviations, and depression more like 0.5. So, you see that there's no real cutoff. And the thing that makes this complex, Andy, is that we come into the world with certain, educational systems and different educational systems and different DNA, and independent of any kind of psychiatric illness, there are going to be discrepancies among all of us in how we do cognitive tasks and how we perform on cognitive tasks. So it's hard to say there's this person has a cognitive impairment and this person does not. It's really a matter of degree and how the illness like schizophrenia or depression or bipolar disorder affects that. It's a continuous measure. And so I think in some ways that's good because we can make decisions about identifying, do we target the people who are doing the worst, or is it impossible for them to get better? Do we target people who maybe still have some neuroplasticity available that could benefit from a treatment or from some kind of educational system that could teach them how to do something better?
Yeah, wow. That was really helpful, the way you described the inverted U being shifted in different directions. I find that extremely helpful in thinking about this. Of course, there are psychosocial determinants, as you've mentioned. There's environmental determinants to some degree. I mean, I'm thinking, for instance, how enriched is your environment growing up? Did your parents read to you and expose you to things, for instance? Are there other risk factors for developing cognitive dysfunction? I mean, it's not entirely genetic or innate, right?
Yeah. Well, it's like that. Those aren't really the main two, I think, right? It's either your genes or your environment, and genes contribute quite a bit. Education is tremendously important, and it, like you're saying, it's more than just what school you went to as a child or as an adolescent or a young adult. It's what was your environment like? What was the how valued was cognition in your everyday life? And so you get some family circumstances, some community areas where being smart isn't necessarily that important. No. Or the things that if you can have great memory and attention, it doesn't necessarily provide a lot of value for you versus other things. And so those kinds of factors all play into whether or not somebody's going to have cognitive challenges when they get older.
Yeah, I'm also thinking of another concept we talk a lot about, and that's early life adversity or trauma or stress. We know that's toxic. I mean, cortisol is certainly toxic to cognition and to the brain. Yeah. So I can imagine that also would predispose somebody to cognitive problems.
Absolutely. So a number of studies have demonstrated that early traumatic experiences are bad for long-term cognition. And certainly people with schizophrenia are more likely to get bullied as in the general population. So that is absolutely a contributor. There's a very interesting set of papers from Ken Kendler looking at this Swedish educational database and tying that to the psychiatric illness database. And what he found was that the biggest predictor by far of schizophrenia was the deviation of an individual from his family cognitive skill. So in Sweden, everybody gets tested all the time and the grades are available. And so if somebody was very different from their family, I think that put them at risk 3 times as much at risk for schizophrenia compared to somebody who had cognitive ability that was very similar. It's hard to know. Is that because the person had some sort of, genetic deviation from the rest of their family? Or was there something about being different in that family that ostracized them from their main unit, of life, and that became a larger stressor?
Well, that is fascinating. Absolutely. I want to ask you a little bit about neuroanatomy, and Steve can certainly chime in here. For a frontline clinician, what's sort of the neuroanatomical aspects we need to think about? What parts of the brain or what circuits of the brain are we talking about here that subserve these functions?
Yeah, so very basically, schizophrenia, there's nothing about schizophrenia that appears to be a localized brain region, right? In all of the brain imaging studies, functional MRI studies, there's a lot of different areas that differ from the general population. But there are some that seem to come up with a little bit greater sensitivity. Things like hippocampal function is really the seat of long-term memory. Prefrontal cortical functioning, where working memory ability, some regular memory, as well as things like executive function and
executive function. Yeah.
So those still, those have been 2 of the main brain regions in schizophrenia cognition since when I was in graduate school, and I haven't seen anything lately that has really changed that, other than to maybe hone in on a little bit more about how those areas really function in humans, and to try to understand how those deficits could lead to schizophrenia early on in life.
Yeah. Well, it's very interesting. The single most reproducible neuroradiographic abnormality of depression is hippocampal size.
Yeah.
And being smaller and shrinkage, if you will. So that's fascinating how that relates. And again, getting to the transdiagnostic nature here of what we're talking about. Steve, what can we tell the audience about circuits that might be involved here, the circuitry?
Well, you might be surprised to know that, again, I keep going back to this thing on my mind today, care court. When you go into court and talk to families and so forth, there's nothing wrong with the circuits because schizophrenia is not an illness. Schizophrenia doesn't exist other than some fantasy of a bunch of mental health professionals. And, it's amazing how many people will argue that. And they don't realize it's not just, in fact, even within our own group, few of us understand that schizophrenia is more than a mesolimbic dopamine hyperactivity, which is this little tiny subcortical region. Certainly, it's important, and certainly it's where we've hit pay dirt in terms of reducing symptoms. Right. But the idea of the circuitry of the brain being some sort of a vast sort of both neurodevelopmental in the first place and then neurodegenerative after you've developed in the second place, illness at the same time, is a bad brain disease. And we've done a bad job over time blaming this on bad mothers, which still resonates in the court system if you talk to judges. There's a lot of judges who don't think this is an illness. And they also think that psychotherapy or effort can overcome the problem. So, although this is kind of crazy in our bubble, I dare you to get outside of this bubble and talk to people that are actually trying to oppose the treatment of people in the mental health delivery system. And so part of the way to actually do this is just to be very confident and have all the listeners here be very confident. This is a brain disease. And it's got a lot of circuits that are wrong. It's got a lot of symptoms that are wrong. It's more than delusions and hallucinations and too much dopamine. That's all true. Right. But it's hardly the whole illness. How many people have you actually reduced profoundly the delusions, hallucinations, and you rarely actually eliminate them, but you can almost do that at the beginning of the illness. And there's still schizophrenia with disabilities.
Absolutely.
And those things are not touched. So that's the issue, is that their brain circuits, cortical, it's a cortical illness.
Okay. Yeah, I'm just thinking how our thinking has evolved. We were just talking a minute ago about neuroanatomy. Certainly when I was trained, we were sort of trained that this part of the brain is not working. This part of the brain is responsible for this. I think we now think of it much more as dysregulation, as a circuit issue like you're talking about, modulation, the yin and yang of glutamate and GABA, for instance, and then the other neurotransmitters modulating that. So I think that's a newer way or a different way of thinking about this. And this is how you can think of it as, again, transdiagnostic. You know, Rich, something you said a second ago really sparked in me when you talked about the literature of people with schizophrenia being bullied earlier. Perhaps that affects them. There's a great literature on kids with ADHD are much more likely to be bullied as well. And think about the social learning that takes place and how that's going to affect your social cognition and all of that too.
Yeah, that's right.
Okay. Let's start to get into treatment a little bit here. Let's talk about some of the challenges in treating cognitive deficits in psychiatric conditions. What would you say are some of the challenges that we as clinicians face?
Well, there aren't any, clear, effective choices, right, in how to treat cognition. In schizophrenia, there's nothing approved for the treatment of cognitive impairment in schizophrenia. Depression, there's not really either. Right. There's, I think, one of the antidepressants had labeling language that it appeared... Vortioxetine, and it's specifically about processing speed, which is why I resonated with what you said earlier. Yeah, exactly. It treats processing speed. But that's just because that was the primary endpoint in their trial. I think that the drug... They used the DST, digit symbol substitution, DSST. Exactly. So...
Hey, Rich, to what extent is the cognition of bipolar similar to the cognition of schizophrenia? The reason I ask is that we may get to this, but on the horizon, there may be drugs that certainly they have changed hallucinations in the muscarinic cholinergic system, and something in September may be coming to the market already. But there's also the possibility that another part of the cholinergic circuits, different receptors, maybe M1, are in the cortex. Is it possible that if the cognitive dysfunction of schizophrenia is improved, actually some of the cognitive dysfunctions of even Alzheimer's were improved? And would that correlate with depression and bipolar cognitive problems, or are these so different that they won't be transdiagnostic?
No, there's zero evidence that they would be different. And I will bet, whatever you'd like to bet, that if any drug is approved for cognitive impairment in any of the three major conditions, schizophrenia, bipolar disorder, major depression, that the next move from that company will be to develop a program to see if it works in the other two, because that's the nature of cognition.
But also, you're humble, but it's also the nature of your work. I mean, you have taught us that there's overlap, and then these circuits are transdiagnostic, and that gives us, me as a pharmacologist, great hope that building upon your foundation, that I actually think, I'm hopeful that, for example, maybe the M1 agonists in the world, of which now there's a gold rush. I mean, there must be 10 companies working on this. And if they hit one, if they hit the cognition of schizophrenia and Alzheimer's and bipolar and depression, there's a very good chance that we're going to have a pro-cognitive therapeutic on the horizon, based upon the fact that the dimensions are somewhat similar and the circuits are somewhat similar across these disorders. Yep. Would you say that, Richard?
100%. And, if you look at the Karuna, they have some ancillary studies there on cognition where they found that, xanomeline, which is an M1, M4 drug, I think, that it improves cognition and in people who have poor cognition to begin with. And that was a drug that Lilly considered for schizophrenia or Alzheimer's disease at the same time.
Yeah, xanomeline was originally studied for Alzheimer's dementia for the cognitive aspects. And believe it or not, Rich, there was a signal on the ADAS-Cog. Yeah. But it was just so hard to tolerate. But it worked especially well on the neurobehavioral symptoms, and that's where they went over to schizophrenia. So I think, Steve, you're onto something here about M1 agonism.
Well, we pretty much exhausted any pro-dopaminergic approach. If it was going to help this cognition stuff, it would have a long time ago. Yeah. And we haven't got anything yet from the glutamate or GABA domains that are looking like it's pro-cognitive. I have great hope that the cholinergic system might be sufficiently important in regulating these circuits and functions that basically targeting them could be therapeutic. So hold on to your seats. The other thing, Andy and Richard, I've been in this game for 40 years, and it seems to me that I have never seen a drug come into psychiatry where the first indication was either the only indication or even the best indication.
Yeah, so that's true.
You're going to have M1, M4 agonists for psychosis. Hold on to your seats, ladies and gentlemen listening here, because we may have a pro-cognitive drug out of that and others like it.
Yeah, well, that's because the diagnostic categories are inappropriate. right? I mean, I know we have to do something, and it's fine, and they're needed for insurance reasons and so forth, but then that's not how the brain's organized. So if it works in one, it might work in the other.
Wait a minute, you're telling me the brain didn't evolve out of the DSM committees, but the DSM committees had brains that evolved into the DSM? I had it backwards.
I think it was off the stone tablet somewhere.
Yeah. Well, Steve, it's interesting. You were talking about the cholinergic system. You and I have been very involved over the years with some nicotinic agents for cognition, which have had somewhat disappointing results. And certainly we know, Rich, that nicotinic receptors and nicotinic dysfunction may be involved with schizophrenia as well. Yep. So there's been various nicotinic drugs, and then there's been
I don't think we should give up on that yet. I mean, there are problems with the trials, but I think there's a signal there. Now, some of those drugs are too old to be picked up again, for commercial reasons. Yeah. But boy, I think alpha-7 nicotinic agonists, they're not dead in my mind. You may need an allosteric modulator because the nicotinic system is very funny. It gets tolerability. It
desensitizes super fast. Yeah.
You smoke a cigarette, you're already intolerant by the time your cigarette's done. But
so with ensanacline, right? Once ensanacline had negative results in phase 3, Steve Brannon, who is sort of the company fixed it up, except for Steve Brannon, and he did some additional analyses that were very appropriate, not like these post hoc, we're just hoping for anything. But getting rid of things like patients who didn't take the drug at all, those kinds of analyses. And when you did that, there was a signal with ensanacline. So I always thought it was a bit of a tragedy that it wasn't able to see the light.
No, wait a minute, Richard. Wait a minute. These drug companies are supposed to make drugs that work if you don't even take them. You mean you're only making drugs that work if you take them? Oh, what terrible kind of a system is that?
Exactly.
It's crazy. Isn't it crazy?
Well, Rich, it's funny you say that because I was involved with the development of bitopertin as well, which is a glycine transporter 1 inhibitor. Same thing there. There was absolutely signal there, but the trials were so messy that they killed it. They essentially killed.
Well, we're going to get another chance, right?
There's another one coming. Boehringer Ingelheim has a drug, right?
And we'll see. Hopefully the trial will be done in the next year or so, and we'll see whether that worked. For cognition. Cognition is the primary endpoint there, so we'll see.
Yeah. Well, let's talk a little bit about then some of the drugs in development, maybe some of the mechanisms that are being looked at. We've talked about cholinergic system. What other mechanisms or systems are being targeted?
So first of all, there's a neurocrine trial. And if you recall, levotaxistat increased the serine levels caused by DA inhibition. It positively impact the activation of NMDA receptors. And so that drug, it was interesting in phase 2, the primary endpoint was negative symptoms. So it was a negative symptom trial. Was negative, but secondary endpoints were cognition, both performance-based cognition, and then cognition measured by interviewing the patients or relatives or caregivers, somebody who watched the behavior of the patient. And both of those endpoints were fairly robust in terms of improvement with that drug. And so, the company is now running a larger phase 2B trial with cognition as the primary endpoint. So I think that's a space to watch.
Yeah, that's a D-amino oxidase inhibitor, D-amino acid oxidase inhibitor, DO inhibitor. And it's interesting, that and the GlyT drug that mentioned Boehringer Ingelheim, very similar story. Bitopertin was originally being studied for negative symptoms, and then same with this other drug, they found a secondary analysis, cognition. And both of them are really working on the same system in general. Steve's the one who taught me that schizophrenia really comes from dysfunction of an NMDA receptor on a GABA interneuron in the prefrontal cortex, right? Did I say that right, Steve?
Well, that's what they're leading.
And that's what we're trying to fix. Yeah, that's what we're trying to fix here by these ways of increasing the coagonist, if you will, at the NMDA receptor, glycine or serine.
Well,
so those are interesting.
And related to that, and Steve, I'd like to hear what you think about the Recognify RL-007 program. That's a small molecule. It modulates the brain's excitatory and inhibitory balance through GABA B and cholinergic related mechanisms. So that's in early phases, but it looks like the company is committed to finding whether that improves cognition in schizophrenia.
Yeah, so we're talking about various pharmacologic interventions, but, we have to also talk about there is at least one digital intervention.
Yeah.
There are several being looked at. We know that there is a digital intervention. Click Therapeutics is partnered with Boehringer Ingelheim for negative symptoms of schizophrenia. Right. But you could imagine digital interventions could also be useful for cognition.
Yeah, absolutely. And I think that Click Therapeutics has that in mind too, as they go forward. They've this partnership they have with Boehringer Ingelheim has been good because they're both looking at some of the same things. I do think that type of digital intervention is what will happen in the future, right? Andy, well the difficulty with carrying out clinical trials.
Yes.
In the way that they're done now, they tend to be very burdensome in psychiatry, a lot more than in other branches of medicine. And I think that the digital solutions are available where you can measure cognition, you can measure with ecologic momentary assessment, the work of Harvey, other folks, where just you ask somebody in this moment, what is your mood? How about, then the next day, in this moment, what is your mood? It is far superior to asking them, what's your mood been like over the past 2 weeks? I mean, that kind of question is just so bizarre. If you think he just asked you, so what's your mood been like over the past 2 weeks? Rather than, here's what you would like on Tuesday, Wednesday, Thursday, Friday, what you said, this is what your life really like. Same with cognition too, small cognitive tests at various points through the day, rather than having to go to a clinic and sit through 3 hours of assessment. So I think that those types of assessments are coming. I think those types of interventions are coming too.
Yeah.
And I think that patients are going to be much better off once we get to that phase.
Well, you're beginning to already see the synergy between, if you will, psychotherapeutic or at least cognitive rehab plus drugs.
Right.
You're seeing it in the psychedelic area, where you're seeing it in the PTSD area, where some of these drugs induce a mental state that, if coupled with we're still floundering as to what we're to do in that period. But again, it's any clinician listens to this knows that 1 + 1 = 3.
Yeah.
Drugs plus psychotherapy gets you a much bigger outcome than the parts. Right. And another thing I can mention, Richard, do you know, I'm sure I'm not teasing you, but let's have the audience ask. Do you know what the biggest signal is for, like the state hospital system where I work, for the most violent patients have psychosis plus what? In order to be the most, we call them frequent flyers. These are the people that assault staff frequently. And the answer is poor cognition.
Yeah.
And it doesn't even matter what it's caused by. So one of the things that we're trying to make maybe the median patients with schizophrenia into someone with a college graduate or something. But the idea is you could go into very sick people who have very poor cognition. And by the way, the only thing that really works for these people with a big signal is clozapine, which works, in people not only that have the psychosis, but have cognitive problems with psychosis.
Yeah.
If we could have a pro-cognitive drug, it would help violence.
Right.
Yes. Well, Steve, by the way, it's fascinating you say that, because we now know that part of clozapine may be muscarinic agonism, that the active metabolite norclozapine has some muscarinic agonism. So back to your muscarinic theory. Yeah.
Very interesting.
Rich, I'm wondering, are there any currently available digital interventions, cognitive training, or digital type therapies that can be used? I know there's forms of cognitive remediation, but what's available?
There may be. Fortunately, I haven't kept abreast of what's available to people for everyday use.
Sure.
There has been nothing, my space has been more what is going to get approved, what has enough evidence to get approved for use and labeling and marketing. And nothing is close to that.
Nothing yet.
So, a couple of years ago, I looked at the App Store for things that had to do, I think at the time it may have been sleep. So I looked at sleep and how many apps were for sleep. And it was, in the hundreds.
Yeah.
How many of those are actually approved to be methods of assessing sleep at the FDA level? And there were none. And so it was just a completely, they're different worlds now between regulatory science and the generation of revenue for digital tools. it's just going to take this stuff, as you know, Andy and Steve, it takes time to do all of the right studies to make a definitive claim that something does a particular thing. And as much as we may bash the FDA for being slow, it's essential. And so I think they have to, to be committed to something more than revenue generation, you have to go through the process of making sure that the thing you have does what you say it does. And those are coming, but it just takes time.
Yeah. Richard, I'm going to have to correct you here. You said an oxymoron, and I'm going to say shame on you. That's called regulatory science. I'm teasing. But, one of the things I'm going to ask you about regulatory science, another thing I've never been able to take you aside and ask you is, can you ever envision a time when post-hoc, post-randomization analyses will be accepted, such as you randomize people, and if they don't take the drug, and in fact, you could also then have a placebo marker to see the placebo people that weren't taking placebo, and just not drop them out and analyze the people on drug. Now, to me, as a non-statistician, that sounds like a profound statement of the obvious. How many drugs would have actually been approved if they had done that? But once you randomize, sucker, you're done. And can you envision regulatory science, if there is such a thing, to actually advance for some of those things?
No.
Well, why couldn't you, Rich? Why couldn't you pre-specify that you're going to do that, though? If you pre-specify that my primary analysis is going to be only on the population with, let's say, measurable blood levels or some other way of documenting, they won't accept that, huh?
No, you can pre-specify that, but it won't get you the drug into the market. And the rationale is that taking a drug is a process, right? And and getting the drug, taking it, putting it in your mouth, swallowing it, having it work. Those are all things that humans do with variable degrees of success, right? So, I remember, the example that always comes to mind for me was that I remember when I was young hearing that the condom was 80% effective. And I thought, 80%? Are you kidding me? You're telling me 80% of the time people don't know how to use it? Well, that's right. Exactly right. And so should we only look at the condom efficacy from those who put it on effectively and don't take it off? No, you got to look at for the way it's actually done. And so I don't see that changing. Now, Steve, you're a pharmacologist, right? So the question you have is, does the drug work in the body? Yes. That's just a different question than what the regulators are asking.
Yeah.
Wow.
It's not unrelated to a trial that Synovian once did with Latuda and lorazepam, and I saw that they were doing a separate analysis of it in which they were actually measuring levels long after the drug was approved and so forth. They had this old stuff.
Yeah.
And it turns out that 40% of the placebo people were taking Zyprexa.
Yeah, right.
And
or Risperdal.
about 40% of the Latuda people have no drug.
Right.
And despite that, the drug still worked. You can't believe it. So to put that kind of barrier in front of innovation is going to stifle innovation. But maybe I'm just wishful thinking. Yeah. I think we need people like Richard banging on the table saying you need to do post-randomization statistics that are common sense. Otherwise, we're never going to have any new drugs. Anyway, that's just me. I'll get off my soapbox now.
Well, the three of us cranky old guys have seen several drugs that we actually thought worked that didn't get approved or had failed trials, as we talked about a couple of them already. And it is difficult to demonstrate that a drug actually works in real patients.
But just sorry to be the devil's advocate here, but as a psychologist, right, I understand the power of belief. And so I think, I'm blocking the name of in a series 4 or 5 of those fast-acting antidepressant trials where there were these huge responses and patients were saying, this drug has changed my life. And it was a blinded. And so then
you're talking about the Rapasnil trials where I did those trials, Rich, and they fooled us. the first treatment, everybody got placebo, but we did not know that at the site level.
Right.
And there were some dramatic improvements.
Yeah. It wasn't.
You're right.
Was there Repassa?
Wasn't Repassa?
I don't remember, but the drug
it was another one, yeah.
But afterwards, like you're saying, and the punchline is that the patients, they even did separate analyses. They said, let's look at these super responders, because the super responders, of course, they have to be taking the drug and not the placebo. It turned out that wasn't the case.
No.
And so I think, especially when you get these ground swells of belief that the drug is working, and now with social media where people say, I was in this trial and it's spectacular, you've got to get in this trial. Well, there goes objectivity out the window.
Yeah, and that's something at the site level that's difficult too. If we get too excited and enthusiastic about some new treatment, it gets transmitted to the patient. And it also points out the difference between the clinic and research. In the real world, hope and optimism and the placebo effect is my friend. I mean, that's part of the therapeutic process.
Yes.
But in clinical trials, of course, placebo is my mortal enemy. Right? So you're right.
Although I think some of the academic medical centers are doing a very good job of getting rid of the placebo effect. the way I get treated as a patient, for instance.
Yes, I understand what you mean.
The warm and fuzzy is all done. There's one thing I want to just go back to is...
Yes, please.
Because we were talking about what works and the fact that there are no drugs. But I really want to emphasize for clinicians especially that there are ways to help a patient's cognition that doesn't involve a new drug. And so some of them are just, the obvious staples of wellness, right? Like adjust the dose according to cognitive impairment. And I think that a lot of times psychiatrists and neurologists, they really just treat based upon the efficacy of what they think is the disease-related symptom. Yet that can cause some quality of life issues because higher doses sometimes will lead to greater cognitive impairment. And I think clinicians keep in mind the idea that a higher dose of a drug may cause greater cognitive impairment and cause a lot more difficulty in a patient's life. They really have to weigh and have to balance those out. So that's one thing.
Yes.
The other
excellent point
is just street drugs, right? Street drugs, alcohol. Obviously, these things are impairing. People with psychiatric conditions do a lot more of that stuff. And then, the stuff mom always said, right? Sleep, diet, exercise. Well, she was right. I mean, lack of sleep will have a dramatic impact on cognition, more than the effect size of any drug. And more than most psychiatric conditions. So I think some of these things, clinicians can just help their patients pay attention to this stuff. And there also are these computerized cognitive remediation programs that are available. Some of them show some benefit. So I think there's some things.
I had one thing. In the state hospitals, in addition to your wonderful laundry list there was one other thing that we found out because of practice. And the most powerful thing, other than what you mentioned, was to stop anticholinergic load.
Yes, I was just going to say that,
and
Steve.
So it's amazing. So on these violent people that I told you had cognitive problems, the only intervention really that we had was to look at their med list. And you would be amazed, and the audience listening here to be aware, there's a lot of drugs not billed as anticholinergic that have muscarinic anticholinergic properties. And if the load is too high, you're poisoning the brain. So if you stop poisoning it, at least you're not making it worse. And so sometimes that actually means you're making it better.
Yep. Yeah. Exactly.
Yeah. This concept of anticholinergic load or anticholinergic burden, I just recently learned, guys, there's a website called anticholinergicburdencalculator.com. And you can enter the names of all the medicines they're taking. And there are medicines we don't think of. For instance, furosemide, Lasix, has anticholinergic effects. Wow. And our patients are taking many medicines. If you take a couple of them that maybe don't have a lot of anticholinergic, but have some, now you get clinically significant anticholinergic effects. So that's one of my big soapboxes, guys. I completely agree. And Rich, I'm so glad you mentioned those things you did, because I don't want our audience to get demoralized. There are things we can do right now, some of them simple, lifestyle interventions. And I hope that people are listening are getting a little bit of hope and a little bit of optimism. If I could just leave us with one last thing. I don't think we really touched well on, are there some practical strategies, Rich, for a clinician to just do some basic assessment of cognition, not only to identify deficits, but maybe to monitor your interventions to see, am I making some kind of difference here?
Yeah. Yeah, and it's a great question. There's always been this search for like a quick cognitive task that people could do.
Yeah.
I don't think that's a great strategy to get, to get like psychiatry. I think one of the options there, though, by the way, is that there are some tests that you can give in the waiting room, right? That are valid even when the patient is by themselves. And so I think that some of those tests would be good. I think if a clinician really cares about tracking cognition over time, these things are digital. You can invest in an iPad, have the patient, if they're sitting in a waiting room, have somebody hand them the cognitive test. Takes a few minutes, and then you can track over time. I do think that if one of these drugs for cognition and schizophrenia is approved for that purpose, there will be, sponsored proliferation of those tools because they're going to want clinicians to be able to track cognition over time, watch the improvement with the drug. But a clinician who really cares about this can get out front and do that type of assessment. So I think that's one of the main things. I think that the way we do this in research and in clinical trials is just not appropriate
not practical. Yeah, the matrix battery is not something that can be used practically, much as I am in awe of your work in putting that together with the FDA. But how about this, Rich? Something that I do is I just ask patients about what they do in their everyday life.
Yeah.
What are the tasks that are important to you? What is your role? These kinds of things. And how are those going for you? It's a blunt instrument, but at least it's some way of measuring the functional aspects of cognition.
I meant to say that, Andy. I meant to say two things, and that was the second one. So absolutely.
Okay.
Great. No, just ask the patient, and if you can get if you can get an interview with somebody who sees them, the patient every day.
Yes.
Or regularly say, how are they doing? Are they doing these things? Like, are they reading a book? Can they pay attention to a movie? Can they talk about things that they saw? What are their conversations like? Are they getting information? Are they able to get information? What are their limitations?
Yes.
I remember when we were doing some studies on assessing visual cognitive processing, we found that half the patients who were coming from the state hospital couldn't read. Why couldn't they read? They didn't have glasses. And so some of these real basic things, but once you start to look into whether a patient, how they're doing with the cognitive task, you find out some things that you can really help with. And boy, it's really great to be able to just, hey, I just made it so that person can read now for the next 12 years because they have eyeglasses on before nobody was asking them.
You just touched on something else. There's an association between hearing loss and dementia, and that correcting hearing can improve cognition.
Yes.
Similar to what you're saying with the eyeglasses. It's amazing. Well, guys, I can't believe that an hour has gone by this fast. This has been a wonderful conversation. I hope it's been valuable to our audience. And Rich, I really want to thank you. I have learned a lot from you over the years. I think you've done tremendous service to our field and hopefully helped further the idea of bringing new treatments to the clinic. And so thanks very much for your time, Rich.
Thanks so much, Andy. It was a great pleasure. And thanks, Stephen. Nice to spend time with you guys.
Yeah. Steve, final words?
Yeah, a real giant of our field. I agree. It's on your shoulders that we're poised to actually help cognition, at least from my point of view in pharmacology. And a pleasure to talk with you. Thank you.
Yeah, I think the work that people like you and Phil Harvey have done have just been so important. We all owe you guys quite a debt.
Yeah.
And also Michael Green at UCLA, we should not forget too, some great work he's done.
Tremendous work they've done.
Yeah. Well, I want to thank you, our audience, very much for listening. And please remember to check out our other podcasts in the series, the NEI Psychopharmastahlogy series. We also have other podcasts on their own. As I mentioned, this particular one is going to be part of a series we're doing on, rather than Rich, untreatable, perhaps difficult to treat, inadequately treated. That might be a more appropriate way of saying this. Yeah. And for other resources that NEI has, please go to our website, NEIglobal.com. Thanks so much.
Thank you for joining us for another episode of the NEI Podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit NEIglobal.com.
A rate cutoff for the 2024 NEI Synapse is fast approaching. If you have yet to complete your registration for the conference, known as the Nerve Center for Optimizing Patient Care, do so today before rates increase. The 2024 event is being held April 19th through the 21st in person at the Red Rock Casino Resort and Spa in Las Vegas and via simulcast online. Secure your spot today at nei.global/synapse.